introduce our first speaker, who's a good friend of mine as well. This is Dr. Allison Wheeler. She's an attending physician at Seattle Children's Hospital and the Washington Center for Bleeding Disorders. Her clinical interests are focused on hemostasis and thrombosis, and she has a particular clinical interest in female bleeding. Dr. Wheeler's research career has primarily focused on hemostatic disorders, and she has a robust collaborative research portfolio with industry and individual investigators. Her personal research focus mimics her clinical interests as she investigates the understanding and management of females with heavy bleeding. She is currently working to investigate the efficacy of Levendestrant IUD in females with heavy menstrual bleeding and the presence and absence of other bleeding disorders. And her academic work also includes in the investigation of diversity, equity, and inclusion in medicine. So I want to welcome Dr. Wheeler to the podium.
Okay, so I really loved everything they just said, but particularly the first thing that Jen said, which was that she really wants this to be a conversation. And for those of you who are at ISTH, I gave a similar talk there, and when I finished, and sort of as I was giving it, I kind of felt like I wished it was more of a discussion, because I don't feel like I'm providing necessarily a clear answer in giving this talk. I'm more providing some tools that I think we can think about using together. So I'm actually gonna make you guys answer questions in the middle of the talk, but they're not hard. They're just your opinions, I promise. But I would love if somebody sees a slide and they really have something that they wanna say about it or that they think is really pertinent that I have skipped, please just shoot your hand up, or the room just got really dark, so yell loudly, do whatever, because I absolutely agree. We are all friends here, and this is so much more a discussion than me just bantering up here. So that being said, we're going to talk about clinical endpoints for this of severity in heavy menstrual bleeding. These are my disclosures. And just before I start talking about this, I think it's important that we think about sort of the definition of menstrual bleeding and heavy menstrual bleeding. So normal menstrual bleeding is going to last about 5 days. People lose around 30 to 50 milliliters of blood, whereas heavy menstrual bleeding historically has really been defined as this greater than 7 days of bleeding or greater than 80 milliliters of blood loss. But I think it was 2012. I'm looking over at Maureen to see if she can nod at me. When a number of different organizations in the gynecology space redefined heavy menstrual bleeding as an increase in menstrual blood loss that interferes with a female's physical, social, emotional, or material quality of life. So this is a much broader definition, and it encompasses people whose menstrual bleeding can affect them for various different reasons. And when I thought about putting this talk together, I think actually both definitions are important, especially in our space where we're talking about females who have bleeding disorders and potentially are going to have, really the volume of their blood loss is going to be really impactful and important. So while I do think quality of life is critical, and we'll talk about quality of life measures towards the end of the talk, quantification and actually thinking about the volume, or at least semi-quantitation, is I think really important as well. And why do we want to actually have this talk? Why can't we all in our clinical space and our research space just sort of know that people have heavy menstrual bleeding? And some of this is really just thinking about how we're reporting this information and how we're studying this information. So this was a paper that came out that looked at clinical trials focused on menstrual bleeding. And as you can see, there were 45 different clinical endpoints that were measured in various trials. And they were grouped into 14 different groups. And so you can see really clearly that there's overlap here, right? And the problem with overlap like this is it sort of limits our ability to compare data, to compare trials, to move back and forth in between with the work that we do. So I think thinking about these clinical endpoints and as a group, asking ourselves, what clinical endpoints do we want to focus on? Do we want to be sort of our endpoints of heavy menstrual bleeding is really critically important for allowing us to move the field to get forward together. Okay, so this is the proposed clinical endpoints that I have put together, thinking about quantifying menstrual blood loss, and we'll go through some measures of that. Thinking about how menstrual blood loss leads to different new diagnoses, both in the hematologic and gynecologic space. Of course, thinking about how we should look at our quality of life assessments. And then finally, satisfaction of care and improvement in care from our patient's perspective or our participants' perspective if we're thinking about clinical trials. Okay, so again, just sort of some structure. This is the nomenclature for the ISTH BAT. This is the menstrual bleeding categorization. And the reason that I put this up here is I actually do think that there's value in this. It provides sort of a framework for how we can think about the impact of heavy menstrual bleeding, thinking about both how much someone's bleeding, sort of looking at that number one category, thinking about the quantification, the flooding, the clotting, what your PBAC score is. We'll go over the PBAC. But it also captures the impact of heavy menstrual bleeding in sort of the time off school and work. And it also captures the interventions that are needed for your heavy menstrual bleeding. And so actually using this as sort of a scaffolding, I think is a nice way to consider the quantification of menstrual blood loss. Okay, so the PBAC. We all talk about the PBAC, the pictorial bleeding assessment tool, quite frequently, and so it would not be a talk about quantification of heavy menstrual bleeding without talking about this. So this is a semi-quantitative tool. It was initially published, the first paper was published in 1990, and what this involves is it involves the patient or participant, depending on if you're in clinic or in a clinical trial, counting the number of pads and or tampons that they're using, and defining sort of how saturated they are based on these pictures. And then each picture sort of has a point scale, and somebody does this for every day of their menstrual period, and then you get a total point score at the end of the period. As you can see here, this is sort of the original PBAC data, and what they did for the original PBAC was they had females do their PBAC score. They also had physicians do the PBAC score based on the pads and tampons that the females brought in. And then they did alkaline hematin method that allowed quantification of the menstrual blood loss. And you can see here, this is the data looking at the patient's PBAC scores, and you can see that there is sort of a linear pattern comparing the patient's PBAC score on the horizontal axis to the menstrual blood loss volume on the vertical axis. And really there's a fairly tight, is this a pointer? Nope, it's okay. There's a fairly tight connection sort of at the lower volumes, and we do sort of space out as we're starting to get into the 300, 400, and 500 point score. But what this really defined was that a PBAC score of greater than 100 was correlated with menstrual blood loss of greater than 80 milliliters. So that's sort of that definition of heavy menstrual bleeding. So what are some challenges? What are some sort of problems with the PBAC? Because we all know the PBAC isn't perfect. So the first one is I think fairly obvious. Everybody looks at things differently. So there is a decent amount of variability within the PBAC. Most of that variability is going to be in between people, not one individual person scoring themselves differently. But you can see this data on just under 120 females. They all, at least the median of them, had heavy menstrual bleeding, so PBAC scores of greater than 100. And you can see that as we look at the variability between the scores that are happening in this study, there's quite a bit of variability. So if somebody scored perfectly the same every time, they would just be on that middle line. And you can see that people had higher scores and lower scores as they went sort of through their PBACs. And so this is a representation of intra-patient variability, but the inter-patient variability is actually quite a bit larger. So you can imagine that this sort of brings up the possibility of this score not being terribly accurate. So often what people recommend that you do is you do PBACs for either 3 months or 6 months, and you sort of get the average of that or the mean of that time, and so you can sort of understand somebody's bleeding over time. I learned earlier this week from Maureen Baldwin, that should just say 3 months, because it really just takes 3 months of your period to get a sense of sort of where your bleeding is. So we can sort of solve this variability challenge by looking at somebody's PBAC over a 3-month period. That was definitely not what I meant to do, so we're just gonna click through that. There's a couple of other potential solutions, though, in thinking about longitudinal heavy menstrual bleeding quantification. Robert Sidonio, when he did the Willate study looking at prophylaxis, Willate prophylaxis, he wanted to quantify heavy menstrual bleeding and the impact of heavy menstrual bleeding, so he sort of came up with this heavy menstrual ABR, or annualized bleeding rate. And what he did was he asked the question, during a menstrual period, how many days did the menstrual bleeding impact the participant's life? So whether it impacted their ability to go to work, to go to school, to do their daily activities, that sort of defined a day. And so he quantified how many days, annualized over a year, a menstrual period would be impactful. I also learned earlier this week from Dr. Baldwin about the Beasley criteria, which I think was published in 1986. So all of us reinventing the wheel. We can go back to when the Red Sox lost the World Series when I was younger, and we can use this criteria where basically, and this table was auto-colored when I pasted it into this PowerPoint, so I apologize that it's so poorly visible on the screen here. But what this score does is it uses a 90-day interval, and females are just saying, this is a day when I had menstrual bleeding, this is a day when I had spotting, and then it allows quantification of the number of days, each of those days, and there's definitions for more heavier bleeding and definitions for spotting. And so we can actually go back and not only think about sort of the intensity of menstrual flow, but we can also think about just quantifying using one of these tools. And so just sort of some additional options. All right, another problem with the PBAC is that the PBAC was made quite a while ago, 1990, right? And they used a very specific pad and tampons. And so what happens with modernization of products, right? So menstrual products are now thinner, they're more absorptive, the visualization is different. And so Paula James, a number of years ago, put out a paper where she validated modern menstrual products using the PBAC scoring system. And so they used specific volumes of I believe it, blood mixed with saline to sort of mimic menstrual fluid. And then they put various volumes onto products, and then they had 5 different volunteers who were familiar with the PBAC score those products. And so that allowed sort of a modernization and a new scoring system. So you remember the original points that I showed up there? It was like 1, 5, 10, 1, 5, 20, I believe. So now, according to this paper, it's a little bit more complicated. You can't actually see all of those numbers, but we start with, on the tampon side there, a regular tampon, a super tampon, getting different point values based on how saturated they are. In the pads, there's regular pads, heavy pads, overnight pads. And so it's a little bit more complicated, but it does really appreciate sort of the newer products a little bit better. A third challenge with the PBAC is it's pads and tampons. And we know that there are a number of other menstrual products that are on the market now. So another great paper by somebody who's sitting in the 1, 2, 3, 4th row there, Bethany, is looking at what is the volume of blood that can actually be saturated into some of these more modern menstrual products. So Bethany looked at disposable pads and period underwear, at tampons, and at menstrual cups and menstrual discs, and very carefully had specific methods for allowing those products to become saturated. And this is the data that we see from her. So these are the volumes of blood that are absorbed by individual products. And then you can see sort of the visualization of that. I think some of this is really impactful. So earlier, greater than 80 milliliters of blood loss for a menstrual period would be considered heavy menstrual bleeding. And if you look, like the regular disc, I don't know what brand F was, but brand F is 80 milliliters was held by that one product. So some of these patients who are coming in to see us who are saying, like, I fill a disc a day. I saturate these super pads every day. Like, they're losing a lot of blood, and we're not necessarily capturing that with the tools that we have now. So just some things to think about. This is the Hemophilia Federation of America. This is published on their website looking at the PBAC, but they've added in the menstrual cup. And this isn't validated, so let's just acknowledge that. But the menstrual cup does have like volume lines on it, so it is possible to sort of consider the volume of blood that's lost using that product. But again, not something that's validated and not something that's used in all of our studies that's quantifying menstrual blood loss. Okay, so this is supposed to be an audience response question. I'm not sure if it's going to work out that way, but just go to the next one. There we go. Okay, so nope, big, huge lie. Wait, can I go backwards? Okay, this was supposed to be automated. Now y'all are going to have to raise your hands again. Okay, so I'm curious, if you were to run a clinical trial, if you were to put together a clinical trial, or if you were able to completely control everyone who ran menstrual trials in the country, what would you use? Raise your hand for me if you would use the original PBAC, that 1510, 1520, keeping it simple, using 1990. Okay, no. Oh, wait, yeah. I am so proud of you. I don't know who you are. I'm sorry, but I'm so proud that you raised your hand. So maybe we can meet later. Or maybe we've met before and I'm old and you're far away and a little blurry. Okay, so I'm assuming everyone's going to raise their hand and say they would use the modern tool. Okay, so this is an agreement pretty much for the entire room. So that's exciting, right? We can move forward with that. There's additional aspects of the PBAC that I didn't really get into because, I banter a little bit when I give talks. But we can also capture whether or not blood clots are there, whether they're large and small, whether there's flooding that's there. We can capture this additional product. So who would capture clots when they're doing their PBAC? I'm going to go with like 2-ish thirds of the room. What about flooding? Okay, maybe a little bit more, or people are raising their hands sort of a little low. Who would capture the menstrual cup, knowing it's not validated? Okay, that's maybe like a half to a third. Okay, so this is good. Like, we can sort of ask ourselves these questions and think about moving forward. And then, how do we even feel about the PBAC? It's like what all of us use, but there are these other methods. There's, the heavy menstrual ABR. There's this 1986 Beasley criteria. Do we think the PBAC is the appropriate tool for us to be using? Or should we be, okay, yes or no? Is the PBAC it, or should we be adding additional measurement tools? Raise your hand if the PBAC is good enough. Raise your hand if you think we need, in addition to the PBAC, another collection point. Okay, cool. See, I actually feel like we're in fairly decent agreement here. So now we're just going to move forward, and everybody's going to do it that way. We'll send out an email later, tell you what you said. Nobody's allowed to do anything different moving forward. Okay. Okay, so back to the ISTH bat. It's sort of like the weighted center of this talk. We're going to keep coming back here. So interventions, I think also just capturing like what interventions were done to control heavy menstrual bleeding. And I think of that in two different categories. What interventions were done to control acute bleeding, whether that acute bleeding is happening on a baseline of no medications or somebody's on a medication and then suddenly has a heavier period, right? So we can think about using antifibrinolytics in our patients with bleeding disorders. We can think about using factor or DDAVP. We can think about using increased doses of estrogen. We can think about increased doses of progesterone to help control bleeding. Interventions, asking our surgical colleagues. There were a bunch of OBGYNs and adolescent medicine folk in the room who can do things that I can't do to help control bleeding. And then I also think in the acute setting, thinking about the medications that we give in response to heavy bleeding. Like, did somebody need a blood transfusion because of their acute bleeding? Did somebody need to start IV iron because of their acute bleeding? I think capturing these endpoints is also important. And then similarly, what are our patients using, or what do our patients have to use to control their bleeding sort of more chronically? Are we using hormonal methods? Are we using regular use of our hematologic drugs? Or are we using some sort of surgical intervention, hysterectomies, uterine ablation to help control bleeding? And I think capturing this data is also really critically important. Laboratory changes. These are I thought about this a lot. I felt really lame when I put this slide together because I was like, what laboratory changes are going to be important to collect? And I'm like, this is, like, I tried. I really wanted there to be like 6 or 7 boxes on this slide. So I'm gonna jump ahead to a question that I think I have later, but does anyone want more labs for this? Like, what am I missing? Because I feel like, okay, sweet. Okay. Oh, yes, that's a huge one that I'm missing, and that's really sad that I didn't put that in because I would chastise anyone who consulted me without a retic. Okay. Okay. Yeah, we can all get we can. I. No.
Too fast.
No. Yeah. Yeah, I think a lot of times we all do consults, right, where we're like so annoyed that there's no retic along with our CBC. Oh, look, we're getting microphones. Okay, I apologize. I know I physically have. I recognize you, but I don't know you.
I was just going to say that the ferritin is obviously very helpful, but as we all know, it's an acute phase reactant.
Right.
And we just completed a chart review recently where we discovered the difficulties of interpreting our ferritins correctly because we happen to get CRP sometimes, and when the CRP is high, during one point you have certain ferritin and you have another ferritin the next time. So longitudinally it may be hard from a research standpoint, unless you have all with CRPs or all without CRPs, but of course, clinically we'll always get a CRP.
Yeah.
We would get it if someone was sick, but just that's always a confounding.
Yeah. So maybe adding sort of just similarly to adding retic below the hemoglobin, maybe adding like a % saturation below the ferritin, because I do think there's some literature that shows that can be helpful in looking at iron deficiency in the context of somebody who has inflammation.
Yeah, I think every patient who
Oop.
is working on it.
Somebody
Every
yell
patient
at
who
me.
has anemia should get retics.
Yeah.
I mean,
No,
that should
I-
be a standard. I don't know why we don't order it, which is, it's a,
Yeah.
and it's done in the same machine at the same sample, and it doesn't cost much.
Yeah.
So I think we need to change that practice, and we need to educate everybody to start ordering retic, and they should get all parameters: absolute retic, percent retic, and reticulocyte hemoglobin. And that gives you a much better picture of iron deficiency, not just the current, but latent and impending.
So I think we can add this to Maureen's educational efforts. I think the other thing, again, that I just heard this week was thinking not only about hemoglobin and iron, but also in the context of how much iron is being replaced. Michelle Lavin deserves the credit for that. And then I'm going to let one more hand, and then I'll move on because I have no idea where I am in time. So Carrie, if you could wave aggressively if I'm taking too long, but or someone else, anyone, but.
So I appreciate all the smart people in this room. Maybe I'm totally wrong. I always get the whole CBC, the iron studies, and then I get B12 and folate because I always feel that those are players in the creation of new red blood cells, and lots of our patients actually need B12 replacement.
I think that's a really good point, and I think the reason I didn't write just CBC and iron studies on there is if all people are collecting, if half of us are collecting hemoglobin and half of us are collecting hematocrit in our research, then we're going to have a little bit of a discrepancy. So I actually think even we probably all are getting a CBC, but I think asking ourselves like what metrics within that do we want? And as a pediatrician, B12 and folate is something I don't think about nearly as much, but this is why we're here, right? Like we need all of us to sort of think about, because I think in the adults that is much more important.
I think Hemoglobin is more accurate.
I like hemoglobin. I'm a hemoglobin
Hematocrit
girl,
can
but
vary depending on so many other factors.
but okay. So this is great. I'm not taking notes, but hopefully someone is. And then, so I also think another nice endpoint that we can capture is what comes of our heavy menstrual bleeding. Like what diagnostic considerations are thought about and what diagnoses are given to our patients, whether they're the hematologic diagnoses that I've put up, sort of what I think is, sort of an appropriate workup to come up with those diagnoses, but then also what gynecologic diagnoses. This is actually kind of a weird slide. I put the workup for the heme and then the diagnoses for the gynecologic, but I think that shows what kind of physician I am. And I would encourage anyone who's on the right side of this slide and their expertise to tell me how many things I'm missing and or what's wrong. I do want to just throw out this slide, and again, in the interest of time, I'll go over this really quickly, but just remembering that some of our diagnostic tools need to be repeated. Some of our diagnostic tools are influenced by outside components, such as the inflammation affecting our ferritin. Inflammation is also going to affect von Willebrand factor. This is data from on the left is data from Megan Brown and Robert Sidonio's study looking at change in von Willebrand factor in emergency ER setting compared to a clinic setting, showing a mean change of 30% when factor VIII activity is greater than the upper limit of normal on initial presentation. So that was a really lovely paper that I've enjoyed. The one on the right is data from a collaborative work that was led by Angela Wyand, and one of her junior faculty, whose name is unfortunately eluding me at the moment, showing that there's an indirect correlation between hemoglobin and von Willebrand levels. So as we become more anemic, our von Willebrand levels are going up as well. So sort of the number that's been proposed as a strong negative predictive value of the diagnosis of von Willebrand disease is 100. I caution everybody to think about that with caution, because I think depending on how inflamed somebody is and what exactly is happening, we can get diagnoses. I remember when these papers came out and I was talking about them with the gynecologist I used to work with. She was like, no, I had this patient who went from 140% down to 35%. And she's like, so you can't use this 100. And I looked in the chart, and when she was 140%, her hemoglobin was 4. And so I was like, okay, I think this number's good, but then let's take a deep breath when there's extreme circumstances, but just something to think about. Oh, dude, here's the QR code. This is where all the questions are. Now I understand what you were saying. Okay, I didn't mean to do that. All right, so instead of going through the QR, we've already talked a little bit about what's maybe missing from the laboratory changes, what's missing from the interventions. Is this diagnostic evaluation that I've sort of put forth feasible? And I don't know if sort of half the people are pulling out their phones. I don't know if it's worth it, and I've already sort of bantered and used a bunch of time, but look, yeah, they decided it was. So I think that we can think about those questions and talk about those questions we already sort of have. I love that people raised their hands and started talking in the middle of a talk. That makes me actually makes my heart really happy. I think that the things that FWGBD can do here is what I've sort of keep coming back to and talking about. We can support validation. We can work on validation of the menstrual cup. I believe, Jenna, you're already working on this. So, everybody's supporting that, reading those papers, implementing that when it comes out or before it comes out. And I think really this second bullet, collecting consistent data, collecting the same PBAC data really is critically important for all of us to be able to compare the information that we're getting from our patients and within our studies. And then really maybe coming up with, sort of an intervention and diagnostic toolkit, whether it's a red cap form that everybody can use the same red cap form or a sheet that everybody can use to fill out. But if we can be consistent with collecting this data, then I think that FWGBD can really sort of help us move that forward. And we can all commit to working with them to move that forward. Okay, again, no idea where I am in time. But quality of life. New diagnosis of heavy menstrual bleeding includes changes in quality of life, and so I think capturing quality of life is really important. Is that actually right? Okay, I never know if the timers are right. I'm always like, did it reset? Okay, so I think quality of life tools really should encompass multiple different modalities, and I think that appreciating that the quality of life tools are imperfect, and that we probably do need to use more than one of them is important, but also remembering sort of as we're thinking about our patients or our participants in our clinical trials that we don't want to burden them too much. So we really only want to choose quality of life tools that are going to be pertinent to the research that we're doing and are going to be used sort of as we make those conclusions. So there are general quality of life tools that can be really helpful and really help us define the impact of disease. So the PROMISE was put out by the NIH a number of years ago. This tool is actually really nice. There's core elements and there's disease-specific elements that can be used. And you can sort of pick and choose which parts of the PROMISE that you use, and then there are normal values that allow sort of for comparison within that tool structure. Additional sort of general quality of life measures, the PEDS-QL, the short form, either 12 or 36. These sort of all can be tools that we can consider, and what I would suggest is that sort of within reason and within consideration of our patients and participants that maybe we try as much as we can to think about using the same tools so that we can compare our data. There's also sort of additional considerations to put in there, and this is probably something actually that I should have put in the patient satisfaction part of this talk, but just thinking about how many days of school or work have our patients missed. The last time I gave this, somebody commented that nothing that I talked about captured sexual function within our patients, and so thinking about that, I think that's the pediatrician versus adult provider in me. I'd like to think, but I do take care of adolescents, so probably not so much a good excuse. But asking that question of our patients and getting comfortable always asking our patients about how their menstrual periods are affecting sexual function is really important. So I would include that in our data collection as well. Thinking about a heavy menstrual bleeding specific quality of life tool, the one that I sort of have come to like, and people can tell me that they think I should like a different one, and I'm more than happy to be open-minded about that, is the menstrual bleeding questionnaire. This is a 20 question for adult or 21 question for adolescents tool that really captures some general information about the intensity of menstrual flow as well as the impact of menstrual bleeding on quality of life. It's been validated in both populations. It's showed really good consistency over time. And so that's something that's really nice about it. The difference between the adult and the pediatric tool is really subtle. It includes things like using the term school instead of work when thinking about missed days. And then one of my very favorite questions in this tool is actually only in the adolescent model, and it's, are you bullied or teased at school because of your menstrual period leaking through your clothes? And I think that's another sort of aspect of menstrual bleeding that's really important in the quality of life realm to capture. So, you know, again, people can tell me that there's another tool that's stronger, that's more impactful, that's validated in a better way, you know, whatever you want. But I think, again, us sort of thinking about these menstrual related quality of life tools and then trying to be consistent with them is something that would be really lovely. And I saw your hand go up. That's so interesting. I wouldn't have thought about that. That's something I wouldn't have thought of, but also really kind of awesome. So that's, and potentially changes the quality of life, but that's actually still impactful, right? Information, like we still, within the consistency, can be nice. Right. Yes, and I think that that sort of does bring up the point of, changing a question. It's always lovely to change a question in a tool to make that more updated, to make that more consistent with your population. It does invalidate the validation. And so I think that that's a question to ask, though, right? Like, are we willing to invalidate the validation to get a nuance of data that's important? And again, I'm not advocating for one or the other. I'm advocating for us coming together and thinking about this together and trying as best we can to be consistent. Maybe it's a follow-up question that you ask later or something to that effect. Do you want?
I was just going to suggest that if we wanted to actually be able to include that kind of data, we could start with just adding the question. So maybe not, but have you had to work remotely because of heavy menstrual bleeding? Or take classes online,
Yeah.
and then eventually validate that as a separate question potentially.
Yeah, absolutely. As long as we don't consider it in the tool scoring, then we can do that, and we just need to think about it and brainstorm how we want to do that. But I think that's a great idea.
This might be a really dumb question, but is there any linking like the quality of life, like assessment to validated mental health assessment as far as like a lot of anxiety related to all of these things and then kind of incorporating those scores?
So I didn't specifically look for that, but when I was sort of looking at menstrual health quality of life tools, I didn't see that, or that sort of association being linked. But lovely segue. I also think it's really important that we capture just some mental health quality of life aspects. And the reason that I've chosen these two, and then Eric, I do see you, is this generalized anxiety disorder questionnaire and then personalized health depression scale. These are like super short, right? These are 7 questions and 8 questions each. And like, again, we have to be respectful of our patient and participants' time and what we're asking them to do. But I think, we could choose between a mental health tool that has like probably 100 questions or much shorter ones. And so I think thinking about that and being thoughtful in our considerations of what tools we want to use is important. Eric, you had a comment. Oh, sorry. All right. So I think that is really important because I do think in all of our patients, I think about adolescents more aggressively in my head, but mental health can really be tightly linked to menstrual bleeding, and so I think that that's important to capture. Okay, and then finally, I'm thinking about satisfaction of care. I'm going to end early. That's crazy. So I put this sort of top data up. I think I originally had some animation on this slide, so just ignore the stuff on the bottom. But this top study was actually a study that looked at various questions to try and appreciate somebody's menstrual bleeding, and then tried to compare patients who had what they considered sort of normal heavy menstrual bleeding and severe heavy menstrual bleeding. And severe heavy menstrual bleeding was defined as somebody whose menstrual bleeding resulted in a hemoglobin of less than 10. And if you look at all of these questions, how long, number 1 is self-judgment. Do you believe that you have excessive menstrual loss? And then how many days, how many pad counts, how many sanitary products, do you leak? And when comparing heavy menstrual bleeding to severe heavy menstrual bleeding, the only metric in these questions that demonstrated statistically significant difference in the multivariate analysis was the self-judgment question. So I do appreciate that sort of just asking people, like, do you have heavy bleeding, has a lot of potential dirtiness to it from a data collection standpoint. I do think it's really important that we maintain a level of sort of respect and understanding of how important that top question is, and thinking about how can we consider asking that question in a way that we feel like comfortable and we feel like it can be helpful for the data. This is actually also was a self-perception tool where this was a like sort of I can't think of the word right now, where you like choose where the little thing goes. So this was talking about your heaviest bleeding, and you had no bleeding at all. You got a 0. Heaviest possible bleeding I've ever seen is 100 points. And when patients rated their periods on this visual analog scale, that's what it is. Thank you. There was actually a fairly tight correlation between where patients put themselves on this visual analog scale and what their PBAC score was. So again, just sort of thinking about, asking our patients how they feel and asking our patients what they think about their bleeding is, I think, important. And then finally, and since
The other issue is that most of them don't think that they have heavy periods. So I have so many girls with hemoglobin of 4, and they tell you, no, I don't have heavy periods. I say, sweetheart, you're losing blood somewhere. And we have checked other things, of course, to be sure. But then many of them, and remember, if the mother has heavy periods and no one recognizes it, and then the sisters and everything. So, and then you also have the one that the perception is that, oh yeah, I bleed so much, and then normal hemoglobin, normal ferritin, normal retic count. So what will be then the endpoint of asking that question if it's not correlating with the labs?
Yes, and I do think that we all have those stories of people either having what we consider to be horrifically heavy periods, and they're like, no, dude, that's totally normal, and vice versa. And so as I said, I do think that this data would need to be thought about sort of with some perspective, with, I don't know if caution's the right word, but I do think just appreciating that there is value in still collecting that data, still asking that question, and still, as we approach our patients and as we think about, clinical trial participation, just considering some of these metrics as well. I think also, and I see 2 hands and I'll get to them. I think also, as we jump to the next slide and think about satisfaction of care, there can be sort of comparison points within of a patient's self-perception before and after treatment, and sort of thinking about the quality and the benefit of treatment. So I think from that perspective, we could also use that data potentially. And there were 2 hands over here. I don't know.
Hi, sorry.
Ooh, she got the mic.
Very good. I work in pediatrics as well, and I think one of the biggest issues for us is that kids don't bring them back. So we don't get the data because they don't do it. I mean, we ask them to take pictures of it, but girls don't want those pictures on their phone because then when they go into Snapchat, that all gets uploaded, right? So I was just wondering, and fairly new to this community, but worked in pediatrics for 29 years. I didn't know if anyone has started to develop an app for collection for PBAC.
I think there have been apps that have collected PBAC data. I think REDCap is a really strong tool where we can, text message or email surveys to our patients or our participants. We can ask them to complete, the PBAC on multiple days in a row. So I think there are some tools that can be helpful with that. But I don't think that there's like the PBAC. There was a group called, I want to say like the Sisterhood, that Robert Sidonio developed an app with them that did the PBAC for a while, but I believe it has been technologically told it's too elderly to be in the App Store anymore. And I don't think there is a replacement, although Sarah, you were doing some work using app tools for the PBAC or for quantification of menstrual bleeding. Okay. Yes.
And the other thing I was going to say, I also work in pediatrics, and I have the same experience where you'll ask someone, are your periods heavy? And I honestly wonder if it's like a Back to the Future version of heavy, where like, does heavy mean to you what it means to me? Does it mean something different in the future? Because they'll say, yeah, they're heavy. And I'll say, how many pads or tampons or whatever product you're using are you changing in a day? And they'll say 2. And I'll say, okay. Are they full of blood, kind of half? What do they look like? Oh, I don't know, about half. Okay, can you explain to me why they feel heavy to you? Oh, well, I have these terrible cramps. And so they don't think of menstrual blood loss as the word heavy. I really think that that's a confusion for at least adolescents.
So I think that is an excellent point. When somebody is having difficulty with their menstrual periods, there's a lot of different reasons why that can be the case, and making sure that we're thoughtful about asking our questions and digging into all potential symptoms that could be influencing their answer is really important. I also would, and this is in no way, shape, or form a judgment to you. It's mostly a judgment to me, but just all of us just sort of remembering and hearkening back to Bethany's work, that sometimes 2 pads is a lot of blood and is heavy bleeding. And so I think all of us, myself being the person I'm talking to the most, like remembering that and thinking about that when we're collecting data is really important. I feel like you passed, yeah.
So, one confounding factor here is iron deficiency anemia. Because if you have iron deficiency anemia, you can have mental health issues, depression, anxiety, and so forth, as well as if you have heavy menstrual bleeding. And if you have those conditions, then you feel bad, and your score is always going to be 100. So it's sometimes very difficult to tease out, the chicken versus the egg. So it is just very nuanced.
I think you're 100% true, right? And I think that's why, and it sort of, I hit it on, I think, the last slide of the talk. I would advocate for us coming up with a way to collect, maybe not every single piece of data that I've presented here, but a combination of data that captures each of the categories at least, so that we're not relying on just one piece of information, but rather considering the old and new definition of heavy menstrual bleeding, bringing all of that together in our data collection so that we can have that sort of full scope.
I completely agree with you, Shweta, that, iron deficiency, but iron deficiency is the result of heavy menstrual bleeding, isn't it?
Yeah.
So, but yes, I agree with you, but you have to rule out the other reasons. And if you find iron deficiency to be directly related to heavy menstrual bleeding, then I think it is the endpoint, right? It is a measurable endpoint for heavy menstrual bleeding.
Bethany.
Sorry.
Oh, Claudia.
Hi. I just was going to say I take care really only of teenagers and some young adults, and I don't ask them, do you have heavy menstrual bleeding? I mean, by the time they come to our clinic, 90% of the time it's because they have heavy menstrual bleeding. So I just ask specific questions, especially most of them come with a mom or a parent, and sometimes there's a difference of opinion about what's heavy, and so we just ask objective questions. I mean, none of them are totally objective, but more specific questions, because I think there is just such a wide variety of interpretations of heavy, as has been noted.
Okay, I'm going to let Bethany say something, and then I'm going to speed through the next slide because it's really just, and then we'll be done.
Sorry, maybe I'm jumping the gun then. I just was going to point out that one thing nobody in this room has said, what's great? Alkaline hematin. And that is what the FDA requires to label something for menstrual blood losses. So just to Maureen and Jen's wonderful exhortation to us, we should be thinking about advocating with the people who know less about this than us, which is the FDA.
We're gonna chat a little
Just
bit
say
later.
that.
I'm gonna tell you something later. Oh, sorry. No, they haven't changed their minds, but I think there's a group that you should get involved with. Okay, so this slide is really just acknowledging that there are different ways of collecting patient satisfaction, and that I think in the context of this space, one thing that FWGBD can do is help us, and we can work together to create sort of a patient satisfaction tool that we think could capture these clinical concerns and the change in somebody's heavy menstrual bleeding and how that's affecting their life in the context of either a clinic or a clinical trial. Okay. And then this is just my final slide, because I think I probably have 2 minutes now, just reiterating everything I've sort of already said and we've talked about. And I love you guys for raising your hands and talking during the talk and helping me get through this time period that they've set aside for me. But I think, again, capturing this quantification, the medical impact, the diagnostic impact, and quality of life, and finding a way that as much as we can, we're doing that consistently among ourselves and each other so that we can collect data, understand females more, and then compare our data when that's the appropriate thing to do. And with that, I'm done. Oh, there are 5 minutes for questions. I think. They're like, Allison's been a wicked slacker this whole time, just pointing at people and not making them do. You guys could have interrupted. Yeah, do it. She should, aggressively. Sarah.
Hi, Sarah O'Brien, pediatric hematology. I just, in the spirit of keeping it real, I did vote for the complicated PBAC back at the beginning. But I'll be honest that in our current study, we're using the traditional PBAC because we're in a primary care setting, and we need to be in and out of the room as quickly as possible. And also, I am embarrassed to say that we had to throw away 150 participants, which was so sad because my research assistants were not collecting the data correctly. So I think we need to keep in mind that we're used to these instruments, but they are really complicated for, 22-year-old first job out of college trying to collect these data with patients who also aren't familiar with the tools.
In the spirit of full disclosure, I too am using the original PBAC in the clinical trial that I'm working on starting up right now, and some of that was the simplicity. We're also hoping a lot of our patients are amenorrheic, but I think that. But that's actually a really good point. Like, we all know what we think is ideal, but then reality. Yeah.
Aisha Zia, pediatric hematology. Can you comment on whether these tools and endpoints are also applicable to heavy menstrual bleeding due to anticoagulation?
I am looking at Bethany because I don't know why like a quantification tool wouldn't be, but I don't know what the data and the literature. I actually, if would look to you and Bethany for that answer, but I know that Bethany, you gave an ASH education 2 years ago.
So there's been one study. I'm loud enough without the microphone. Sorry. There's been one study. It was the Medea study. It was in adults. They were looking at TXA versus switching to dabigatran, and they did use the PBAC. The fatal flaw in that study was they required a cutoff of 150, so they never enrolled enough participants. So I would say, as far as it is, the standard PBAC is the standard in that area. But I don't see any reason why these all wouldn't pertain. You just have to keep in mind that like the first period might be the worst and things might level off around period 3, and so just think about the timing.
Peter?
Thank you. So I have a few thoughts. The first was that using the original recipe, PBAC, is probably the most utilitarian for a clinic space because the modified one is very challenging and complicated to use. And I think one solution to that has been that if you're collecting data for research purposes in a research study is to use that diary, but then also provide the menstrual products that you intend for everybody to have. As that way there's at least uniformity or rigor in your collection of your data. I think the longitudinal change over time is important, but when we looked at IUD placement in our patients with bleeding disorders, we didn't assess based on PBAC, we assessed based on satisfaction with bleeding profile. And I think that's an important data point that I agree is qualitative, but is a desired endpoint that the PBAC may not capture specifically. The third thought I had was that when we use the PBAC, I'm sure there's this desire to be uber quantitative and try to find statistical relevance in what we're doing, but I think the threshold is important. Whether somebody reports a PBAC score of 850, which I've seen multiple times in my work, to a PBAC score of 150, both individuals are experiencing heavy menstrual bleeding. So if the question is, do you have heavy menstrual bleeding or not, or how much of a horror show is your bathroom, are two different things. The next thought I had was that if we're utilizing this for clinical work versus research, those are two different things. And so I think it's important when we talk about how we use these tools, it's a question of, are you using it to assess whether somebody has heavy menstrual bleeding, or are you utilizing it to assess a phenotype or assess an intervention. And I think that the rigor part of it is part for research. The PBAC part is a way to objectively assess whether what you're doing clinically for this person's made a difference.
Peter made excellent points, and in the interest of time, I will not respond to each of them, but I will just let everyone know that's Peter Seigan from Penn.
I'm Janice Bacon. I'm an OBGYN from Columbia, South Carolina. I cannot get any clotting studies drawn in my office because they don't seem to get to the main hospital lab in time to be run before they are worthless. So occasionally we use a screening HemoQ, so that's finger hemoglobin. Is that of any value? I don't use it to assess any long-term bleeding risks, but I can't find any reading material on how this correlates with venous hemoglobin.
I have some thoughts there, but you're sitting next to
Yeah, I can
the more expert.
So I'm Ravi Sarodhe. I do transfusion medicine, hemostasis, and run the labs. So HemoQ is kind of pretty reliable instrument. You can get point of care testing, but hemoglobin value can vary plus minus 1 gram. But if you have 4 gram, then definitely it's bad. So I think it's useful.
Yeah, I've noticed.
But it's not going to be accurate.
I've noticed the plus or minus 1 gram, but I just wondered if it was reasonable or should I just give up on it?
Yeah, I think
It's reasonable.
Yeah, I think again that comes to one of Peter's points. Are we thinking about clinical care or are we thinking about research? And so definitely different spaces.
But again, it depends who's performing it. Make sure that that person is competent.
All right, and with that question, I just again want to thank everyone so very, very much for their participation and help with my talk, because I think you guys made it a much richer 40 minutes, and I really